And I'm going to progress now into PD-1 inhibitors and more for advanced basal and squamous cell carcinoma. I know Dr. Farberg's going to come up and talk about the hedgehog pathway inhibitors after me, so I'm not going to spend a lot of time on those. You know, my disclosure with this is I did the studies with Regeneron on cemiplimab, so I'm probably one of the few dermatologists, you know, in this room that have infused immunotherapy in patients in the clinic and seen the outcomes and seen the adverse event profile that can happen with them. I now have these patients infused by my oncologist because of the nature of the infusion process, but it was nice in the studies to get hands-on and see, you know, what immunotherapy is and what the oncologists are doing with that. These are the high-risk tumors that we sort of look at on a regular basis. You know, Monday morning in the clinic, you'll see these large tumors come in. We'll show you some outcomes. And we have these approvals right now. We have our hedgehog pathway inhibitor group. We have our immunotherapy group with a PD-1 inhibitor pathway for which we have 2 medications. We have locally advanced basal cell and metastatic basal cell. We also have metastatic squamous cell, locally advanced. And then we have pembrolizumab that has the recurrent or metastatic squamous cell and then locally advanced squamous cell, but doesn't have the basal cell indication yet. These are all IV medications, typically dosed every 3 weeks. So just briefly with the hedgehog pathway inhibitors, intermittent dosing is kind of the way to go with it. I'm not going to spend too much time with all this because I know that Dr. Farberg is going to go into it. Management of adverse events with L-carnitine is something we're doing in the clinic quite handily. Just some outcomes and responses. Primarily what happens with hedgehogs in some cases is you have resistance. And so some of the tumors will respond and some of the tumors won't. And that's sort of what led into the immunotherapy. So in the trials, the patients that were enrolled in the cemiplimab studies were failures, either failures from hedgehog pathway inhibitor because they didn't respond to it, or because they had an adverse event profile that was intolerable, so they were allowed to then go into the immunotherapy studies. Although if you look at the approvals for cemiplimab, at least, there's no barrier. You don't have to have used a hedgehog pathway inhibitor first. It's approved, you know, directly, you know, without step therapy before that. Some responses over 23 months, just some outcomes from those, and then the comparison. I'm going to kind of skip a lot of this because I know that Dr. Farberg is going to talk about it, but there are strong recommendations in by different articles that have been published to give us an idea of how well to use these medications. Of course, they've got a strong recommendation for the locally advanced basal cell carcinoma, and of course for basal cell nevus syndrome, but I'm not going to stay too much on this. So I want to go right into PD-1 inhibitors. So PD-L1 expression. So when you're looking at these medications, just primarily mechanism of action, these are uncloaking. So our tumor cells have figured out a way, produce these PD-1 receptors on them and interact with the T cells. They basically have figured out a way, and this is through the sense of self and through the thymus, the tumor cells have figured out a way to cloak themselves. So this is the immune surveillance recognition that they do. And so when you add what's called a checkpoint inhibitor, you block that connection between the tumor cell and the T cell, and the T cells then become activated, become tumor-infiltrating lymphocytes, CD8 positive cells, infiltrate in and around these tumor cells and create a cytokine storm basically around the cells, and that's when you can get that immunological response to help hopefully kill off kill off basal cell and squamous cell carcinoma. So that's the basic uncloaking process that we're doing. Of course, this has been around for a while with lymphoma, with lung cancer, with many other cancers, and we're just now in the past few years have gotten immunotherapy in our dermatology patients. And it's so important for us to be aware of this because we're the gatekeepers. We're the ones that are seeing these cancers in our clinic and that can help direct patients toward this therapy if it's appropriate and in combination with a multidisciplinary team. So it's really important to involve your colleagues with advanced cancer decisions with your patients and go over that with them because you don't want to be the only one sort of manage them alone. So I always say involve your colleagues. So PD-L1 expression can vary a lot on the tumor-infiltrating lymphocytes, so there isn't any real clear correlation by doing that test. These are some of the outcomes you'll see at baseline at week 48. The key here is it can take a while to get a response. It's slower in basal cell than in squamous cells. So squamous cells pick up a response quite early in about 2 months. Basal cells take about 4 months to respond to these IV medications. So here's my guy, 5 cycles of immunotherapy with some cemiplimab. You can see he's an older guy. He's around 90. He walks in the clinic Tuesday morning, hasn't been in treatment for years. with his son. What do I do? He's already got calvarial involvement on CT scan. He's not going to get surgery. There's nothing else that we can do for this guy. So we put him on cemiplimab and started to see a nice response. You can see he's a lot happier. The main concern side effect with our older patients is fatigue. So because we're starting this storm, he didn't really have any side effects as far as no lab abnormalities. We monitor it very carefully, but fatigue is the main thing that the older folks sometimes can get. It can sometimes rise to the surface. This is another patient that just walked in clinic. He worked at the Walgreens around the corner. He didn't want to come to clinic because he was too afraid to leave his job and disappoint his boss. So he had, let me go back. So he had these basal cells all over his body. He had this large one on his arm. It was bleeding in the waiting room. He had his whole left breast was involved with basal cell carcinoma. So it was nothing else that this guy was going right to immunotherapy. And so he got 3 cycles is in the center. As you can see, it started to respond pretty fast. And then on the right is 6 cycles with immunotherapy, and he's still doing well. He's still continuing to improve. In fact, the chest lesion completely went away. It looks just like a pink patch now. So he's going to stay on that medication for a while. When do we stop it? Who knows? At least he's going to be on it for a year. He may be on it longer. If he gets completely clear by biopsy, pathological clearance, then I may at some point decide to give him a break from it. But as long as he's doing well, he's going to continue on it for at least a while. I showed you briefly this other case. This is another one on the back, just a large basal cell carcinoma in an older patient. Again, it's just whether you're going to think about the morbidity of surgery, the morbidity of radiation therapy. I would argue that definitive radiation therapy for this tumor would not be that effective. You need something more, maybe as adjuvant. So adjuvant becomes more important, but is this going to be a patient that you can do surgery? He's likely going to have to go in the hospital to have this removed. It's not going to be something we'd ever touch in the office, and I think David might do it in the office, but I would recommend he go to the hospital and have it done. And then in neoadjuvant PD-L1, so when you're combining PD-L1, PD-1 inhibitors with surgery, so how do you look at this? This is mainly in nivolumab responses. Again, these are bad cancers that are not going to be first-line surgical candidates, and you can get some improvement. And then what you're looking at here is a neoadjuvant study looking at pathological clearance versus imaging clearance, and you can see in the red the pathological clearance when you do this, when you do the go back and check the pathology after treating with a PD-1 inhibitor, you get a better outcome than you could possibly get by local imaging. So imaging doesn't tell us the whole story of what's going on with these tumors, although in the studies we did a lot of imaging. We're looking at independent central review of MRIs and CTs looking at these the tumors, but the pathological clearance may exceed the imaging clearance. So very interesting things coming out. When it comes to adverse event profile of PD-1 inhibitors, any part of your immune system can be affected. It's really the whole body is affected. There's layers of different immune responses that we see, a lot of cutaneous responses, a lot of itching, a lot of bad rashes. Cardiovascular can happen, less common, but it's also GI. Our patients will likely get colitis, autoimmune colitis by biopsy. We've sent patients to get colonoscopies to make sure they weren't having cancer recurrence and discovered that they had autoimmune colitis. They get autoimmune dermatitis. And then, of course, I mentioned fatigue, nausea, diarrhea, and they also pretty much vary. Most of the patients actually do fine. About 5% of them get the grade 3 and grade 4 severe reactions with it, but most of them do pretty well. And when you start to look at the weight, this is the BMI correlation between BMI and increased immune responses with pembrolizumab, you start to see a pattern here, and that these younger patients that have sort of that middle BMI tend to get more of a reaction immune-related, and that can be a good thing in some cases. We start to learn about whether the immune response actually portends a better outcome. So as you get older patients with a lower BMI, they don't get as much of a response and are very, very, very thin. Maybe younger patients, there's a sort of that center sweet spot for those patients. So there's a stronger association of BMI in younger and healthier patients that don't have other comorbidities that may go towards senescence. So we're looking at the immune system here and trying to activate it. Is their immune system senescent? Is it sort of quiescent, or is it active? And that's very important to sort of think about with these medications. Now, when you look at this slide, what you look at is for the ones with the darker are the ones that tend to stick. So now we're learning about these adverse event profiles that come up. Some of them go away quite nicely. So the skin effects and nausea and all that, if you stop the medication, stop the IV infusions, that tends to fade away. But what sometimes stays is the adrenal. The more scary things I'd be concerned about are the endocrine side effects, the hypophysitis, that's pituitary inflammation. Those things can end up giving you a long-term sort of adverse event profile that has to be managed, especially endocrine, because that can become a little bit of an emergency. It's really rare, but my patients, if they have that kind of thing, they're right to the endocrinologist to make sure they're not having any adrenal storm or whatnot, or any immune systems where they're dropping their thyroid levels or raising their thyroid levels too much. So most of the rest of the things usually will fade over time. The most common adverse events are primarily skin and, of course, rash, fatigue, diarrhea, those kind of things are primarily. And so this study sort of looked at the correlation between the immune responses and outcomes. So you can see the hazard ratio column, and you can see the immune responses. So the hazard ratio, higher numbers mean, less survival. And so at the very bottom, any cutaneous diagnosis was actually correlated with improved survival. So when I see the skin rash coming in my patients on immunotherapy, I'm actually like, that's good. I'm actually happy about that. And I also see that with patients a lot of these patients have multiple AKs on their legs, on their face, as well as their skin cancer. And so when you put them on immunotherapy, the AKs light up like a Christmas tree. And sometimes you might think that's the immune response, that's the adverse event rash, but it actually is a positive outcome, seeing that their AKs are responding because they're close and they're being surveilled by the immune system. They're sort of being kept in check by the immune system locally. And as soon as you sort of release that inhibition, they all light up. And so they oftentimes get a nice clearance with their AK. Of course, it's not my everyday go-to AK treatment, but it's nice to see that they actually respond. And then the other thing about the PD-1 studies was they really limited them. The registration studies were limited to healthy patients primarily. They may have had bad cancer, they may have had radiation, they may have had prior surgery, all that, but they were generally healthy patients. So they were not immunocompromised, they were not solid organ transplants, they were not didn't have liver disease, and they did not have HIV. So what about those people? So what can we do for those folks? So this took a look at pembrolizumab in patients with HIV and advanced cancer, just primarily to show you that the CD4 counts remained about stable. So these patients that had controlled HIV were not any more likely to get troubles from this medication than they were if they didn't. So it gives us a little bit more confidence to treat patients with HIV, especially if the HIV is going in well controlled. In fact, pembrolizumab may reverse latency. So HIV patients that are completely that have no viral load and they're on antiretroviral therapy, they still have that HIV in those immune systems that are sort of considered latent. And if you hit them with immunotherapy, it sort of brings those forward and allows the body to get rid of those cells too. So it may actually improve their HIV status going forward long term. So of course, this is simply an early study, so it just may induce the response. If you're treating solid organ transplant patients, very advanced thing, something we do not do in our practice, just due to our community-based dermatology practice. If you look at some of the data, the patients, if they have a bad outcome such as death, it's more likely going to be related to their primary tumor than organ rejection, than the rejection of the organ. So I have a couple of patients in my practice that are sort of between one who had a kidney transplant failure, which has happened, but she's got tons of bad cancers. And so that patient, I actually talked to her about it. She hasn't gone on therapy yet, but she would be someone who could go on therapy between transplants. She's going to have to get a transplant anyway, repeat, so she might get rid of some of her cancer. So just something to be aware of. And then, of course, there's things that can be done to help reduce the risk of rejection. Hit them with steroids a little bit early before you start the immunotherapy. Use a steroid to help reduce that adverse event profile, and then even tacrolimus or mTOR inhibitors are used a lot in oncology, but those kind of things can help to lessen the impact of the immunotherapy, especially in the induction period. So these are just all sort of, clinical things that are being learned as these medications are put into use. The last thing I'll mention is just TVEC. This is for advanced melanoma patients that have already had surgery. So this is a little bit of a new thing. It's been around since 2015, but we don't talk about it during that much. It's a HSV-1 oncolytic virus that was derived from the cold star virus that's modified by gene insertion and deletion. It's for intratumoral, so actually injected into a site of a melanoma that causes tumor cell lysis and actually stimulates the processes in the cell to help the cells sort of blow apart, sort of. It gets a systemic response as well that occurs around the cell, so it induces an antigen expression on the surface of these melanoma cells to help the immune system also to eliminate those as well. And it's starting to be looked at for non-melanoma skin cancer. That I just bring it up so because you may see some studies in the future for your advanced skin cancer patients. So pluses and minuses of immunotherapy. It's an IV infusion. It works for both basal and squamous cell. Most patients do well, and you can combine it with XRT to other treatments as adjuvant, and it typically works better in the clinical setting than it came out in the studies. As far as disadvantages, adverse event profile is concerned, sometimes it's hard to get a durable remission for these patients, and then of course need an infusion given by oncology. So, very exciting time in dermatology for advanced skin cancer. So thank you very much for your time and attention.